Definitive USMLE style question. A 25-year-old man presents to the emergency department with palpitations and lightheadedness that started 30 minutes ago. He has no significant past medical history and does not use tobacco, alcohol, or drugs. His vitals are blood pressure, 110 70 millimeter Hg, heart rate, 180 BPM, respiratory rate, 18 breaths per minute, oxygen saturation, 98% on room air. Cardiac examination reveals a rapid, regular tachycardia with no murmur. An ECG obtained during the episode shows a narrow, complex tachycardia without P waves. The patient is given adenosine, which terminates the arrhythmia. A follow-up ECG in normal sinus rhythm is shown below. ECG shows short PR interval, delta wave, and widened QRS complex. Which of the following best explains this patient's condition? A. Atrioventricular nodal reentrant tachycardia, AVNRT. B. Atrioventricular reciprocating tachycardia, AVRT. C. Sinus tachycardia. D. Ventricular tachycardia. E. Multifocal atrial tachycardia. Answer and explanation. Correct answer. B. Atrioventricular reciprocating tachycardia, AVRT, due to Wolff-Parkinson-White WPW syndrome. This patient has Wolff-Parkinson-White WPW syndrome, a condition caused by an accessory conduction pathway, bundle of Kent, that bypasses the AV node, leading to pre-excitation of the ventricles. Baseline ECG in sinus rhythm shows short PR interval, 120 milliseconds, delta wave, slurred upstroke of QRS, wide QRS complex, 120 milliseconds. Arrhythmia mechanism. In orthodromic AVRT, impulses travel down the AV node and return via the accessory pathway, leading to a narrow complex tachycardia, like PSVT. In antidromic AVRT, impulses travel down the accessory pathway and return via the AV node, causing a wide complex tachycardia, mimicking VT. Management. Acute termination. Adenosine or vagal maneuvers. If narrow QRS, regular rhythm. Definitive treatment. Catheter ablation of the accessory pathway. Why not the other options? A. AVNRT, most common cause of paroxysmal supraventricular tachycardia, PSVT, but does not have delta waves or a short PR interval on baseline ECG. C. Sinus tachycardia would show a gradual onset and visible P waves, unlike reentrant tachycardias. D. Ventricular tachycardia, VT, typically wide, complex, and seen in structural heart disease. WPW with antidromic AVRT can mimic VT but is less common. E. Multifocal atrial tachycardia, MAT, irregular rhythm with 3 or more different P-wave morphologies, usually in COPD patients. Would you like a follow-up?